medicine. So let's go ahead and talk. We'll have a break in the middle of this. I'm going to try to stay on time. We're going to talk about abnormal uterine bleeding. And I think as gynecologists, we say, well, they have too much abnormal bleeding, just do a hysterectomy. But the reality is that a lot of people want to keep their uterus, especially if they haven't had children. So we have to have a lot of things in our toolbox to treat this with. And we're going to go through a lot of things today. I'm consultant for 2 companies, and if I say something about one of those companies, I'll let you know. But one thing I want to start, we're going to talk about a lot of terminology of this. We talked about the definitions of primary and secondary amenorrhea. There are a lot of new classifications, and you notice in the journals now, you're going to see these terms used quite a bit. So this is a normal menstrual cycle. I think we all remember this, and the average cycle is 28 days, and 2 standard deviations, 24 to 38 days. The average person loses about 30 to 45 cc's, but heavy menstrual bleeding is always in the eye of the beholder. All of us have seen somebody that probably uses 100 to 200 cc's and says, oh, that's normal, I always do that. And we have other patients who use 3 pads a day. They're really not having accidents, and they think they're bleeding to death. So it's all somewhat very subjective sometimes. And most of the flow is always on day 1. So again, for those when we're assessing for heavy menstrual bleeding, just remember the first day is going to be the heaviest. It tends to diminish during that time. The follicular phase is fairly variable. The term luteal phase insufficiency has pretty much fallen out of favor. It does happen every once in a while. It's not really thought to be a cause of infertility anymore. We're not going to really talk about luteal phase insufficiency, but luteal phase generally is about 14 days plus or minus 2 days. Yes, we do see women in the perimenopausal time maybe have 11, 12 days, maybe a little bit shorter, but again, the luteal phase is very consistent. For those who might be a resident, anybody resident here? Okay, okay. This is always on the test, so okay. I don't write the test, so I don't have that conflict of interest, but that's always, because people hear about luteal phase insufficiency and they think, oh, it varies, but actually the luteal phase is very consistent. We all see people have 35-day cycles and they ovulate around day 21, so it's a 21-day follicular phase and a 14-day luteal phase. And you can see as we get older, there tends to be less variation. Another fascinating thing is those who follow polycystic ovary syndrome. Many women with PCOS who've always been irregular since menarche turn 40, 41, 42, and they start having regular menses. And that's because the number of follicles are diminishing, serum testosterone levels are diminishing, so that for the first time in their life, they may become a little bit regular. Endometrial maturation, we're going to talk about this because you might get questions on this on tests, but remember is that estradiol stimulates endometrial growth and the progesterone stimulates the glandular secretion, and if fertilization doesn't occur, you have a menses. This is, we were talking in the back this morning about those of us who are a little bit older had to look at histology slides on our oral exams, and that was always a big challenge, and they've dropped that now, which I'm sort of sad they've dropped that, because I think spending a month in pathology teaches us how to question pathologists and at least understand the uncertainty in pathology. Now we're going to really get on radiologists a little bit later. If you can't question a radiologist, if your radiologist doesn't like to be questioned, you need to find another radiologist, because if you look at radiology in standard radiological studies, 20% will be a disagreement if they overread it, so in general. So your interpretation of pelvic sonography is probably better than most radiologists because you have clinical knowledge they don't have. So I'll often trust the OB-GYN's interpretation of ultrasound over a radiologist any day. So this is proliferative endometrium, very straight glands. You can see the gland here in cross-section and this nice nuclei at the basal there. Mid-proliferative, the glands are getting larger. You see no stroma in the edema yet. Now we're ovulatory, you see the basal nucleation here. That's diagnostic of somebody who just recently ovulated. And finally here is, again, you're starting to see loss of the stroma, the edema here, seeing secretion. And so this is a late secretory menstrual endometrium. And again, that's just blood coming out. So we can also see the same thing on ultrasound. In infertile patients, you're going to look at this. You'll see this very thin endometrial echo. And this is somebody who just had a menses, probably on day 2 or 3 of her cycle. This is a mid to late follicular phase. You see this bilaminar pattern. Oh, you love to see that when you're doing ovulation induction. If you don't see this bilaminar pattern, there may be some endometrial issues going on, at least in that menstrual cycle. Here's somebody who's fixing or has ovulated. Here's a nice 22 millimeter follicle on a cycle. Her estradiol is probably 150 to 200. If you're not doing ovulation induction, the pre-ovulatory estradiol levels usually can be about 150 per mature follicle. It could be a little higher than that. But remember, you're going to have these accessory follicles that produce a little bit of estrogen as well too. You still see the bilaminar appearance there. Finally, somebody has ovulated and you see loss of that bilaminar pattern. Here's somebody who's probably 3 or 4 days post-ovulation, somebody later in the luteal phase. And then you see this shmush in there, much or shmuch in there when somebody who's fixing to have a menses there is currently having a menses. This is what happens during a menstrual cycle. 2 things have to do to cause sloughing of the endometrium. One is you have to have progesterone withdrawal. When you have progesterone withdrawal, you have the release of the matrix metalloproteinases, et cetera. And then you have the COX-2 prostaglandins go up, and prostaglandin F2 alpha goes up, which causes myometrial contraction. So both of these things have to happen to have a normal menstrual cycle. This is the current definition. And as I mentioned earlier, the term menorrhagia should be dropped because there's no standard definition of what that is. But it still persists in literature and conversation. And abnormal bleeding is now defined as any departure from normal menstruation or the normal menstrual cycle pattern. FIGO has come in and done a lot of classifications. It has taken ACOG and the Canadian Society a while to adopt this, but these are usually in the International Journal of Obstetrics and Gynecology, which is the FIGO journal. Not a bad journal to look at if you ever have access to that journal, because these papers usually come out in that journal. And is anybody here from Canada? Okay, so later on I will put SI units in here, and I apologize, I have translations for all these, but and we'll talk about some of the interesting drugs they have in Canada as well too. So I always like to see people from Canada because there's different practices and different drugs available in Europe, Canada, and occasionally we have people from New Zealand as well too. So I just spent a week in New Zealand in the hospital. It was fascinating. So I spent a week in a British hospital, and that was like scary. So, ooh, my goodness. You don't have what? You use gloves? Oh, good, okay. But it's pretty scary. This is AUB in clinical practice. We all see it. We see it in our office all the time, and so it's something we have to be familiar with. And this is the new FIGO terminology. You're going to see these terms, and for those of us who hate to learn new terms, this is frustrating, but that's part of the change in medicine. If we wanted to do something the same, I guess we all should become auto mechanics or something. But acute AUB is an episode of heavy bleeding. It needs some type of intervention. See it all the time in office practice. Chronic non-gestational AUB, this sounds like preeclampsia with severe features. Why don't they just call it severe preeclampsia? But I'm just counting the days down till they get rid of that term, severe eclampsia with severe features. I'll make a bet how much longer that term lasts. I don't bet much, but anyway, it's bleeding from the uterine corpus. It is abnormal. And it's more of a chronic thing, so it's been going on for about 5, 6, 7 months at that point. So Here's some of the other new terms. This is from FIGO in 2011. And you can see all these things like polymenorrhea, metrorrhagia, menometrorrhagia. Those terms, bye. I hated them because I never knew what they meant. Now these have actually been very clearly defined. I'm not going to go through these because you have the slide here. Here are the current terms that should be used in literature, and this is what they are. Now this is another one. This is from 2018. They made some modifications to this. And again, this is the International Journal of Gynecology and Obstetrics. By the way, if anybody wants a PDF of any of these papers I reference, I have all of them. Please email me. My email's at the end of the lectures. Give me a little time because I have my day job as being a chairman, and I run our transgender clinic as well as the infertility clinic. So I actually do work. And as I say, I clean the floor in labor and delivery as well too. So I'm real good at that when I'm on call. So I'm better with a mop than anything. So, if I have copies of all these, I'm happy to send them to you. If it's something I don't have, I can get any paper because I'll make the university pay for it and I'll send it to you. So I want to pay my state taxes for some reason there. So please let me know and I'll send them to you. But this is a nice paper to look at. You can see again some definitions here. Flow should be 8 days or less. If it's greater than 8 days, that's considered prolonged bleeding now. And again, that's pretty self-explanatory. Here's some more definitions here from 2018, and those are pretty self-explanatory. These checklists could be nice for patients, especially if you're doing a study, but again, sometimes we do have to educate our patients that having 7 days of bleeding is not necessarily abnormal. Again, most of the bleeding should come on day 1 and 2. If they have heavy 7 days of persistent bleeding, that's probably a little bit different. And again, that's where some of these questionnaires can be useful with patients. Here's some corollaries. Again, there's both heavy and prolonged menstrual bleeding. By definition, heavy and prolonged bleeding is greater than 80 cc's. It's sort of hard to measure 80 cc's, but and we talked about over 8 days is prolonged. And again, what patients think they have and what you and I might define it, that can be quite different. I like personally the quality of life. This is off label now, but this is quality of life. If you have, you have to get out of a meeting or a patient room to go change a pad. If you have to sleep on a towel at night because the pads overflow, that's heavy menstrual bleeding. I mean, that's just being real practical at that point. And I think that's part of a good thing to ask patients as well. Does this bother you? I mean, do you have to go to the bathroom every hour to change? If you do change a pad every hour, is it just spotting? Is it really soaked at that point? Do you have accidents? Have you ever had to go home in the middle of the day and change clothes because of bleeding? Do you have to take extra garments to work? Those are all quality of life issues. Again, there's different ways to look at this. Now, our OB colleagues like to do pad weights. The problem with doing pad weights in gynecology is that most of that stuff is exudation or perspiration. So the best way to quantify bleeding, besides looking at H&H, and again, there's our friend the ferritin, again, is probably do a pictorial assessment. And here's one of several. And this is again from Great Britain. They call pads towels over there. So what do you call them, Canada? Do you call them towels or pads? Pads, okay. So you gotta teach me something. You thought you were getting off easy, didn't you? So, okay. I want you to teach me a lot of stuff because I use all this information. So I'm here to learn from y'all. So, they call them towels over there. I'm sorry, but again, this is a nice thing to look at. And I think the thing which is fascinating, people say, oh my God, I'm bleeding to death. But if you put 5 cc's in the toilet, it looks like you're dying at that point. So you got to be careful about toilets because look what 5 cc's does. It makes it look like you're subbing for Sweeney Todd in there. So everybody knows Sweeney Todd, the demon barber of Fleet Street. So he chops people's heads off while you get a haircut. So, and you can see tampons too. So these are nice pictorial assessments to do, and I actually give those to patients sometimes. It's really to teach them how much bleeding they're really having, especially those that think they're dying because they see all that blood in the toilet. We're going to look at AUB, and traditionally we looked at anovulation anatomic. but they didn't really talk about endometrial dysfunction. And now we have the Palm-coein classification here. And I know a lot of people are going, oh, whatever. I love the Palm-coein classification. I'm an old fart. I mean, I had to learn this, but you know what's so great about this? It really is going to direct